So welcome to the MarkeTech Group's Minute Podcast interview. Today we're discussing Medicare's new value-based incentive payment policy, which will begin providing incentive-based payments to hospitals that achieve certain quality and patient satisfaction scores, starting effective October 1st. I'm Robert Ensrink. I'm a partner and a senior consultant for the MarkeTech Group. And discussing the topic with us today is Dr. Claire Pomeroy. Dr. Pomeroy is the Vice Chancellor for Human Health Sciences at UC Davis and the Dean of its School of Medicine. She oversees the UC Davis health system and its entire academic research and clinical programs, including the 1,800-member physician group known as the University of California Davis Medical Group, the 631-bed acute care UC Davis Medical Center, and the Betty Irene Moore School of Nursing. With an operating budget of nearly $1.7 million, patient visits of nearly 900,000, and more than $200 million in outside research funding, the UC Davis health system is a major contributor to the health care and economy of the Sacramento region. Welcome, Dr. Pomeroy.
Thank you.
Now, did I capture all that correctly?
The operating budget of UC Davis Health System is $1.7 billion, and we're very proud to be an important economic driver of our regional economy.
The extra zero makes a big difference. Thank you very much, Dr. Pomeroy. So before we dive into the details of the Medicare value-based incentive payments, let me start by asking you, how important has measuring patient satisfaction been to the University of California Davis Health System prior to the announcement by the CMS of its new value-based purchasing program?
Well, the patient experience is one of our highest priorities, and we believe that in order to improve that patient experience, we must measure patient satisfaction. So measurement is absolutely essential to improvement, and we are deeply committed to continuous quality improvement to better serve our patients. We've been pursuing formal patient satisfaction measurement programs for really since the beginning of UC Davis Health System for well over 30 years. And with progressively more robust tools, especially in the last 10 years. So this is a long-standing initiative for us, and we think that it is key to accomplishing our mission.
So you mentioned that quality improvement requires measurement and accurate measurement. So what kind of metrics were you using to measure patient satisfaction prior to the CMS announcement?
Well, we currently are contracting with an outside firm and have our internal staff conducting over 21,000 patient satisfaction interviews every year. That includes our inpatients, our outpatients, our ER patients, and our home health patients. We were early adopters of HCAHPS, the inpatient survey, as early as 2008, and also an early adopter of the companion outpatient survey. So we believe in using multiple tools to look at patient satisfaction, look at quality, and look at safety. And we also believe that the measurement is just the first step. We then need to communicate all these results out to our physicians, nurses, and other staff. We have to go on to identify best practices, and then we have to do interventions. The point of measuring patient satisfaction is so that we can continuously improve, so that we can make changes to improve the quality of the services that we provide.
Yeah, it makes sense. So in general, what's your assessment based on those years of measuring patient satisfaction, your assessment of the relationship between patient satisfaction and actual clinical quality of care?
I think that the measurement of patient satisfaction is absolutely essential to driving the quality of care. If we pick the right metrics, then we can pick the right interventions to improve the quality of care. I think that this measurement of patient satisfaction has been key to improving quality, but I also believe that we, like all healthcare providers, can further improve on understanding patient satisfaction and improving quality and patient satisfaction.
Yeah. So how has the new payment program affected how UC Davis Health System is approaching patient satisfaction scores?
Well, we have long done patient satisfaction. We've long used many of the criteria that the CMS will be using. But what we see is that this has, of course, because there are now dollars from CMS attached to it, focused even more attention on this issue. And furthermore, we see that our colleagues and other healthcare institutions are also now focusing on this. And so as the entire industry comes together to measure common standards, we can compare our hospital with others, and that allows us to learn best practices from others. It also allows us to partner with others in order to drive quality of care. Many patients receive care at multiple institutions, and by having this standardization across providers, I think that it represents the next step in our quality improvement efforts and our ability to serve patients even better.
So when you look at that, and you've had metrics now since 2008, you've been measuring these at 21,000 interviews per year. CMS announcement came out. It's going to go into effect shortly. Have you changed your metrics, and how have those changed since that announcement?
We have been looking at all of the HCAP indicators, and we have been looking at the care measures really for a long time. This does focus in on the particular measures that CMS will be assessing and making their financial decisions on. But for us, these are things that we've long been looking at. We've long been looking at are we, getting the right antibiotics to pneumonia patients in a timely manner? Are we reducing healthcare-associated infections? Are we improving pre-op procedures? These are things that we've long looked at. I think that one of the advantages of working in an academic health center is that we have been doing this kind of measurement for a long time. Some of these will be more challenging to smaller hospitals who don't have the track record of having looked at these quality measures for the number of years that we have. So it has not changed our commitment to looking at patient satisfaction, to looking at quality indicators. It has focused attention on the particular ones that CMS has identified. But this really represents for us a continuation of a program that we have long embraced.
Yeah, so you haven't changed your metrics much. The metrics that you were using you found are effective with the new CMS directives as well.
And I would add that, we continually assess which metrics we're using. So one of the important things in measurement is that as you measure one thing, it improves, and then you move on to the next level or the next issue. And I think CMS has recognized this as well. So they have defined the core measures that they'll be looking at for 2013, but they've already announced that they will be looking at additional measures in subsequent years. So this is a premise which we've long endorsed, which is the measurement of patient satisfaction, the measurement of quality, the measurement of safety is not a static process. You don't just define one set of metrics, accomplish those things, and then declare victory. This is about changing the culture so that you are working towards continuous improvement, and that means the ongoing identification of pertinent indicators. So we have not changed the emphasis because of the CMS indicators. It is consistent with what we've always done, which is to continuously evolve these metrics based on areas that we see needing improvement.
Right. Quality gurus like Deming would be proud of that. That's exactly what they've been saying, right? And it's nice to see that being implemented in the healthcare industry as well.
Well, this is, I think, very important that we learn from other industries. You are exactly right. You know, Deming is clearly the grandfather of the issues that we believe in here at UC Davis, and that I believe formed many of the decisions by CMS. And we go on to say, you know, measuring this is not sufficient. Just Deming would have said, it is also essential that we look at interventions and processes. So we do believe in lean approaches, Six Sigma approaches for the interventions, and that is how you get to continuous quality improvement. It's about creating a culture of quality.
Right. So as a result of these measurements and that drive for continuous quality improvement, what new policies or practices, if any, are being implemented as a direct result of this new payment policy? Are there new tracking items, or are there things that you've changed in your billing or the way that you're collecting data?
Well, at UC Davis, we're very fortunate to have implemented our electronic health record, and that puts us in the position of being able to transition from the traditional approach to collecting this data, which was very much paper and pencil, to using our electronic health record to try and capture much of this data. So that's a continuous process, and something that we've been working hard on is how do you arrange your electronic health record to most efficiently capture the information. These indicators, the CMS ones are just one part of the picture. Many payers are requiring us to collect similar kinds of patient satisfaction and quality indicators, so it's a huge time investment. It requires many resources, and the use of the electronic health record is essential to that. So we've been focusing on making sure that our electronic health record can do that. Mm-hmm. We have also looked at the results and said, what kind of interventions do we need? And, for example, one of the HCAHPS indicators is nursing communication. We have changed how our nurses report out to each other at shift. They now do it at the bedside. This allows the patient to participate in that report out, to understand what the plans are, and we found that has significantly improved our scores on nursing communications as assessed by our patients. And as just one more example, in many of our care settings, we've instituted what we call team huddles. And this is where all the members of the care team, physicians, nurses, social workers, receptionists, pharmacists, get together right before taking care of patients in the clinic or on the wards and discuss the plan so that all of those diverse perspectives are brought together. We feel that this helps the indicator of teamwork, which is one of the things that we have found is a powerful driver of patient satisfaction, the understanding by the patient that they're getting a single coordinated message from all the members of their team. So these are some of the new initiatives that we have instituted in order to ensure that we are doing well in delivering patient care and therefore doing well on some of these HCAHPS and core measure indicators.
Interesting. So do you find that the tracking is supporting hunches that you've had, or do you find that the data itself is driving you to say, here's an opportunity where we're a little low, how can we improve this, and then you find a solution? More the latter. So as we look at these indicators and we see areas for improvement, we get our staff together and hypothesize what interventions might be effective, and then we try out the various options and see which ones work the best. So this is the process of assessing, hypothesizing, doing the trial to see how well it works, and then taking those best practices, the things that work the best, and incorporating them into the culture, and then trying new things.
one of the essential things here is that you may be improving your metrics, but have you improved them optimally? And you'll notice that for some of the core measures, the expectation is that you hit this 100% of the time. So even if we improve to 99, there may be an additional intervention that we want to try. So just to reemphasize, this is a matter of continuous improvement, continuously trying new things, and continuously assessing and getting feedback on those new things so that we can really address these metrics and then future metrics to come.
Yeah, interesting. So clearly this has had an impact on what you're doing, but you were doing this already even prior to the CMS mandate. So I wonder, what benefits do you think this new payment program offers hospitals when you look globally, across the U.S. anyway, and the healthcare industry as a whole? What benefits does this new payment program offer?
Well, I think the healthcare industry understands that we have to bend the cost curve in our industry. We have to improve the value that we're delivering for the dollar. When we're spending 16-17% of the GMP on healthcare, we have an obligation to use those dollars in the most cost-effective way, and it's not sustainable. And we recognize that in the healthcare industry. So I view the CMS program as the opportunity to encourage and incentivize all hospitals, and hopefully the entire healthcare industry beyond the hospital setting, to really say, what is the most cost-effective, what is the highest value way to deliver care? This is not something that has always been paramount in the healthcare industry. As you know, the past payment systems have incentivized doing more. And now what we want to do, and I think this program is a step towards that, is to ask, how do we do the right things for the right people at the right time, and how do we figure out what not to do? So it's improving the care that we're delivering. It's making sure that we're delivering the right care. And as we change the financial incentives in the industry as a whole, by measuring the right things and then reimbursing the right behaviors, I think that we can accomplish that societal need of increasing value and bending the cost curve.
Yeah, so really this mandate will provide that extra incentive.
Absolutely. The other benefit of this, I think, is that we find that our physicians, our nurses, all of our staff members, they're doing these jobs because they want to deliver the very best care. They want to bring value to the patients. And so as we engage our care providers in these programs, we find that it actually is inspiring to them. It's energizing to them. They like being part of the solution. They like increasing the value to patients. And so it's had an additional effect of mobilizing our healthcare providers to really make good decisions about continuous improvement. And then the final thing I would say about a benefit to the healthcare industry as a whole is that by having this standardized data across hospital settings, we're able to compare ourselves and then identify where the best practices are. And if we can do that, then we can learn from each other to improve the system as a whole. And that's a very important role that I think CMS is playing in giving us access to comparative data across hospital settings.
Yeah. So what kind of data is there to support that measuring patient satisfaction, which is really a subjective measure of the patient filling out a form or a survey, correlates to better clinical care, better outcomes? Well,
a traditional view has been that if patients are satisfied, that means that better care is being delivered. Of course, we understand that, in fact, there are many other drivers to patient satisfaction beyond the technical quality of the clinical care that's being delivered. For example, the quality of the food in the hospital, or whether there are attractive potted plants in the lobby or easy access to parking. And so some people have said, well, patient satisfaction doesn't always reflect the technical, clinical quality of the care. I would submit that the patient experience has to be measured by both of these things, both the patient's satisfaction, how they experience their care, as well as the technical aspects of their clinical care, because both things drive outcomes. As you have patients have more trust in their care team, have them have a more positive experience, I think that is part of the driver of the outcome, as well as the technical quality of the clinical care. So I think that it's important that we look at patient satisfaction, that we look at clinical quality with measures that have been validated, and also to look at outcomes. If we take all of these together, then we'll get the big picture of the total patient experience.
Yeah, it's interesting. It reminds me of the study that showed that patients who have access to sunlight, natural sunlight, tend to require less analgesics.
And that's a perfect example of the fact that that something like how you design your hospital may not be taught to medical students or nursing students when they go to school, but they are a key part of the patient experience, and they do affect not only how that patient feels about their hospitalization, but it probably has an impact on how quickly they recover and the actual clinical outcome of the encounter.
Yeah, it's interesting. So in your experience at UC Davis, what programs or technologies have you found have the greatest impact on patient satisfaction? Has it been more operational workflow efficiencies or architectural or design changes, or is it something else?
Well, the technologies are dramatic, and so I think the institution of our electronic health record, as well as the personal health record, where patients can view their lab results and communicate with their physicians, I think that has been really important, because no longer does the patient have to experience a lost paper record, for example, and all of the data is always available to all of the practitioners. So we have seen very positive results from having the electronic health record and the personal health record available to our practitioners and to our patients. And I would also add, however, that technology is supportive of a culture of quality and a culture of patient-centeredness that's key. So actually, in the end, the most important thing is the accumulation of all those one-on-one interactions between our providers and the patients. And nothing replaces compassion, nothing replaces human kindness, and nothing replaces a commitment to ensuring that the patient comes first. So it has to be a combination of these technological advances with a culture change that emphasizes the patient as the reason that we do what we do.
Yeah, terrific. So were there programs that didn't move the needle that you thought this might help, and you tested it, but you found that it didn't have a significant impact?
We have many metrics that we don't meet the first time. Just as one example, we have really emphasized how quickly the telephone gets answered in the clinic. As a patient, if you've ever had the experience of wanting to get to your doctor and not being able to have the phone answered quickly, you'll know how frustrating that can be. So we set one of our metrics, how quickly we answer the phone. Some of our clinics instantly did well on that. Others struggled. And so we looked at the reasons why. That's why measurement is important. Then you look at, well, what's making that outcome not as good as we want it? And we identified some cases where we needed to do additional training of our staff, some places where we needed to hire additional staff. So the needle didn't move as quickly in all of the settings as we would have wanted. But the point here is that when the needle doesn't move, that's actually your opportunity to identify the interventions, and we pay attention to this and do the interventions until the needle moves.
Mm-hmm. Great. And what technology or product developments do you foresee coming down the road, or things that are available now that maybe you're looking at implementing that you think can have really positive impacts for helping hospitals meet the CMS mandates, including hospitals that, as you described, might not be as far along in EMR or other technologies?
Well, the number one that I would put on my list would be the electronic medical record. And as has been well documented, many hospitals are really struggling with how are they going to meet meaningful use requirements for electronic health records, especially smaller hospitals and rural hospitals. Mm-hmm. So I think that the adoption of electronic medical records is absolutely important. Second, I would say technologies like telemedicine and telehealth are essential. We understand that, say, a rural hospital in Northern California isn't going to be able to pay for or have the technical expertise to have every technology available to them, every expert available to them. And so telemedicine gives the opportunity for hospitals to access specialty care and expertise anywhere, anytime. Mm-hmm. I think telehealth is potentially transformational for this industry. We're seeing more and more of it happening. Radiology expertise, ICU expertise, specialty consultation delivered over telemedicine. And I firmly believe that's an essential technological development. A third one that I would say would be home sensors or biosensors. I think that one of the frustrations that I have is, yes, we have all of these measures for what we do in the hospital, but what if we could actually detect that a patient was getting sick at home and do an intervention at home that prevented them from ever coming into the hospital in the first place? That's a much more cost-effective approach. So the home sensors that might detect something like oxygen levels falling or fluid overload or blood pressure getting out of control. And I think that there's great potential in the industry to really advance our ability to use sensors outside of the hospital, both to detect illness early and to stimulate wellness. And then a fourth thing that I think is really important is how do we take all this data that we're collecting and how do we put it into registries? And how do we use those registries to assess population health and start looking at what do we need to do for every patient, not just the ones that come to the hospital, but how do we start thinking on a population basis? So what if we could understand a high-risk community that had high rates of obesity, elevated blood pressure, elevated cholesterol, and we intervened on those things before they came into the hospital with strokes or diabetic ketoacidosis. And do that if we collect all this data. And the final one that I would suggest is I think that genomics and the ability to sequence the human genome is potentially transformational for medicine. It allows us to do personalized medicine, allows us to predict which medicines might be most effective for an individual patient. This is a wide array of technical advances that are coming fast, but I think it also is the ushering in of a new era where hospitals and medical technology companies are really needing to partner to figure out, okay, here are the outcomes we want. What are the technologies that we need to drive those outcomes?
Yeah, interesting. So let's flip the coin for a moment and ask, are there challenges with the way that the new payment program for hospitals and healthcare system is being implemented?
I do think there are significant challenges. One, collecting this data is a very expensive process. It takes skilled people, and it doesn't actually, it's an administrative cost that doesn't directly add value immediately. So there are some upfront costs and some upfront personnel issues that have to be faced. The second thing that I worry about sometimes is many smaller hospitals don't have the same kind of infrastructure that we have at UC Davis to collect all of this data. And so are we going to penalize by decreasing reimbursement the exact hospitals who need more resources in order to drive quality? So there's a financial downside for some hospitals who don't achieve those quality indicators. And in fact, those are the hospitals and clinical care settings where we probably need to be investing more to drive quality. And finally, I would say that if these metrics will continuously evolve, and they need to, because most of these metrics are quite hospital-centric. And for most patients, most of our health care is not delivered in the hospital. So how are we going to ensure that we are looking at the complete continuum of care and making sure that CMS payments across the complete continuum of care, and by that I mean everything from wellness programs to outpatient to nursing homes to palliative care, how do we incentivize quality and improve patient satisfaction across that complete continuum? That will require some evolution and improvement in these metrics.
Yeah, interesting. So you bring up an interesting point, too, about the impact on the bottom line. You mentioned for the small hospitals, they're resource constrained, and yet they're the ones that might benefit the most if they could bring in the resources to get the measures, to get the additional reimbursement. So in addition to the clinical impacts of these measurements and the quality improvement programs that they will incentivize, what impact has there been to the bottom line of the business, in your case and overall, based on your communication with colleagues at other hospitals?
I think it's early to say what the true impact of these particular programs are going to be because we're just starting. But I will say that for us at UC Davis, a commitment, our longstanding commitment to measuring patient satisfaction and quality and doing quality improvement programs is absolutely essential because if patients have a good experience, they come back to us, they refer other patients to us, and that directly helps the bottom line. I think that if we're not focused on the patient experience, if we're not focused on patient satisfaction, we'll slip in market share. And so this is integral to the business that we're in, which is serving patients. Yeah. This is not and should not be an optional activity. So this sort of is who we are, and therefore that directly relates to our bottom line. In addition, I think this has made us look at ourselves. All of these metrics, they make us question, are we doing this in a way that's best for the patient? Are we doing this in the most cost-effective way? Are we doing this in the way that brings the most value to society? And we are in a rapidly evolving, continuously changing business. And we cannot practice this year the same way we did 10 years ago, 5 years ago, or even 1 year ago. So this is necessary to maintaining our competitiveness and necessary to achieving our mission.
So when we look at achieving that mission, Dr. Pomeroy, how can medical manufacturers help hospitals achieve their goals in terms of that medical mission and also to benefit from the Medicare incentive programs that have been put in place?
I think that the partnership between medical manufacturers and care providers are key to the future of our industry. One, invent and innovate and discover user-friendly technologies. I mean, the things that we're doing now with, say, automatic pumps or barcoding for medications, these are innovations that have come out of the work done by medical manufacturers and are directly applicable to the work we do in the hospital setting. So we need the medical manufacturers to be providing new and continuously new user-friendly technologies. The second thing I would say is I think the medical manufacturers can help us learn from each other. They can help identify best practices. Mm-hmm. They can help us do these assessments and say which things actually do work in a real-life situation, in a real hospital setting. And finally, I would say the most important thing is we can measure what we're doing now, and that's what these metrics do. Mm-hmm. But in order to really be effective, we have to innovate. And I think a critical role for medical manufacturers is to spur innovation. What is the next thing and the next thing and the next thing so that we can continuously improve the service that we provide?
Yeah, interesting you mentioned the smart pumps. I just recently read an article about how some of the tablets and smartphones are being used to access that data so that it becomes ubiquitous and improves operational workflows.
Absolutely, and there are clearly these technological innovations are secondhand to especially younger generation providers. Yeah. So how do we help people learn by using smartphones and tablets? How do we help them go through their workflow day to day in a more efficient way? And the other thing is, how do patients use them? Because improving health literacy by our patients is key, and they're using many of those apps. So these are all things I think that really are sweeping through the industry, and we need to therefore assess our practices and see how do we incorporate these in a most effective way. And it's not just about layering the technologies on top of our current practices. It's how can these technologies allow us to change our practices, to do things in entirely new ways. And that's what's so exciting about these technologies.
Yeah. So you mentioned a number of times that the term user-friendly. What specific guidance would you give to manufacturers? I think that the two key things that come out of that are that technology will evolve, and that manufacturers can help you as a hospital administrator or as a system identify what's being done and what technologies seem to be effective, but also something about the fact that they need to be user-friendly and it needs to be implementable. What specifically would you recommend to manufacturers to address that aspect of it, the user-friendliness, and what does that mean to you?
I think the most important thing is to listen to real providers as they develop these technologies, and then to test them in real-life situations before they're widely disseminated. And I'll just give one example. So with our electronic health record, we thought, well, this is great. We can put all these alerts in to inform our physicians and nurses about, possible things that they might think about as they put these orders in. Well, the clinicians were getting so many alerts that they started automatically overriding. This has been well documented in the literature in institutions across the country. So what we've learned as an industry is that we need to prioritize and only have the most important alerts come up. Well, this is a process that we learned by assessing how people were using the electronic health record in real-life situations. So I think that, there can be too much technology. It can overwhelm people, and they can start discounting it. What we need to do is make sure it's the right amount of technology and that it is answering the questions that a clinician needs answered, or giving them the information that they need at that moment in the real-life clinical encounter. So I would ask, medical manufacturers to really talk to clinicians while they're developing these technologies. It may be like a cool gizmo, but if it doesn't fit into the workflow, then it's not user-friendly. And then test them in real-life situations, and test them across a variety of situations. Something might work in one setting with one patient population and be completely inappropriate for another patient population. So help us define the appropriate uses. As these technologies become more user-friendly, as we understand where to apply them, then the technology will become more successful. So really we're aligned between the medical manufacturers and the providers in ensuring that the right technologies are available to our clinicians.
Yeah, it's the alarm fatigue issue, right? And making sure that not just technology for technology's sake, but make sure it meets a real clinical need and does solve a problem in a hospital setting.
Exactly. And, one of the most interesting areas of scientific inquiry, I think, is the work being done around the human-machine interface and understanding, well, this machine may work perfectly, but how does it interface with the human being, with the provider or with the patient? And that kind of research, I think, is absolutely essential to ensuring that we adopt the appropriate technologies.
Yeah, so human factor is a key element.
Absolutely.
Very good. Very good. So I know, Dr. Pomeroy, that you have a specific interest in serving underserved markets and underserved patients. So you talked about user-friendliness, about the technology, and we talked a little bit about the new technologies coming up. But how can these technologies be made available to these underserved patients, whether they're in rural or inner-city regions here in the U.S., in the Sacramento area, or globally? And how can those types of things that can improve patient satisfaction best be delivered there? So
the benefit of technology needs to reach everybody. And if technology only goes to a subset of our population, then we won't achieve our societal goal of improving health outcomes for everybody. So one of the things that we have emphasized at UC Davis is how do we partner with underserved areas? And I would encourage other providers and manufacturers to ask these same questions. One example of this is telehealth. As we get our expertise out to distant areas, either within California or around the world, we don't have to duplicate all the expertise everywhere. We just need to give access to it. I think this is a role academic health centers and many others can play in making sure that we effectively disseminate knowledge about these technologies. I also think that we don't want every single place trying to develop these in silos. So take the electronic health record. Can we have some central hosting of the electronic health record rather than expecting every doctor's office to put one in when they may not have the infrastructure to cost-effectively support it? Are there system approaches that we can do to implementing technologies, supporting technologies? One example of this would be the California Telehealth Network, in which there is a statewide vision for how we're going to deliver telehealth rather than expecting everyone to do it on their own. Mm-hmm. I think it's important that we make sure that the technologies are culturally appropriate, that they're available in all languages, and that they are widely disseminated with the kind of support that is needed to make it feasible for people everywhere to use them.
Very good observation. So, Dr. Pomeroy, we're getting near the end of our time, and so thinking back on all the things we've talked about and all the considerations that have gone into the thoughts driving the patient satisfaction system at the UC Davis health system, overall, from all your experiences with these patient satisfaction programs, what would be most helpful to share with our audience?
I would say that the most important thing is to remember the goal here, and the goal here is the patient experience. So I would emphasize patient-centeredness. Mm-hmm. I would emphasize the importance of communication, the communication between providers and communication with the patients. I would highlight the importance of collaboration and interprofessional approaches to this, partnerships with industry. I think also that it's important that we not do this completely with a hospital focus, but look at this across the continuum of care. And as we discussed, this is about the appropriate use of technology, and we have to continuously innovate. But in the end, nothing is as important as compassion, the human touch, and if we emphasize the patient as the reason we do what we do, then we will get to that goal of optimizing the patient experience.
Wonderful. Well, Dr. Pomeroy, thanks so much for talking with us. We really appreciate you sharing your experience with both Medicare's incentive payment policies and the patient satisfaction programs at UC Davis Health System. Just quickly to summarize, what we learned is that first of all, I think patient satisfaction metrics are not an option. You highlighted that it will drive and is part of the continuous quality improvement program, which requires measurement, and it's a first step. The correct measures can help provide guidance for actions to improve patient satisfaction. In addition, having those metrics uniform across hospitals throughout the country allows you to identify, you and your colleagues, to identify best practices at other institutions, and it allows hospitals to better identify opportunities to improve. The partnership between professionals, between hospitals, and also with industry can help enhance patient-centered care. Some of the particular things you mentioned, I think the electronic medical records are key, telehealth, remote biosensors allowing more at-home care and early interventions. Then data mining, having all this data available for preventive interventions of risk groups and identifying risk groups that then maybe we can be better at preventive care. And then genomics you mentioned as well. Technology has to be user-friendly, and it needs to be tested in real-life hospital settings. In fact, many different clinical settings, including hospitals in this country, small, large hospitals, academic settings, but also across different cultures. And then you made it very clear, and I think all of your colleagues in healthcare would agree that nothing really is as important as compassion and remembering the purpose of what we do and the human touch and showing true care for our patients. So we really appreciate your time. Was there anything else that you'd like to say, Dr. Pomeroy?
No, thank you very much. It's been a delight to chat with you.
Likewise.